Quality of optical diagnosis of diminutive polyps and associated factors. Introduction. The American and the European Societies of Gastrointestinal Endoscopy, ASGE and ESGE, have endorsed the adoption of real-time optical diagnosis of diminutive polyps in support of a resect and discard strategy for diminutive polyps and a diagnose and leave strategy for diminutive rectosigmoid polyps. This position was taken following the publication of multiple studies that examined two quality benchmarks set forth by the ASGE initiative to preserve and incorporate valuable endoscopic innovations, PIVI initiative. 1. Agreement of optical diagnosis-based surveillance interval with the pathology-based recommendation in at least 90% of patients, and 2. A negative predictive value, NPV, for the diagnosis of rectosigmoid diminutive adenomas of at least 90%. The majority of studies have reached these benchmarks. Both societies critically add to their endorsements that the two benchmarks for quality of optical polyp diagnosis were primarily met when studies were performed in an academic setting and when participating endoscopists were considered experts with a special interest in advanced imaging. Results from community practice and non-experts without prior experience have been less conclusive. The European guideline therefore supports the adoption of optical diagnosis only under strictly controlled conditions for, quote, experienced endoscopists who are adequately trained and audited, unquote. Apart from the hospital setting and performance by expert endoscopists, there is little information on other factors that might affect the quality of optical diagnosis. The primary goal of this study was therefore to evaluate factors associated with the quality of optical diagnosis using NBI. Pohl et al. Were particularly interested in 4 factors. First, they wanted to examine whether endoscopists with prior experience in enhanced endoscopic imaging, but no experience in optical polyp diagnosis, were better at optical diagnosis compared with those who had no experience. Second, optical diagnosis requires attention to detail and a meticulous examination, very similar characteristics to those that promote adenoma detection. The authors were therefore interested to understand whether optical diagnosis would differ between high and low adenoma detectors. Third, the authors wanted to assess whether cap-assisted colonoscopy improves optical diagnosis, considering that a cap attached to the tip of the colonoscope may stabilize the polyp and enhance reading of the polyp surface pattern. Finally, Pohl et al. Aimed to examine whether the ability to perform and integrate optical diagnosis into practice can be maintained over time with brief intermittent refresher training. Background and study aims. The aim of the study was to identify endoscopist-related and procedural factors that may be associated with the quality of optical diagnosis of diminutive polyps using narrowband imaging, NBI. Patients and methods. All subjects who participate in a randomized trial on cap-assisted colonoscopy were eligible for the current study. Optical polyp diagnosis was an a priori outcome of the initial trial. 10 participating endoscopists used NBI to assess all of the diagnosed polyps as adenomatous or non-adenomatous in real time and provided a degree of diagnostic certainty. The main outcome measures were quality benchmarks of optical diagnosis. Negative predictive value, NPV, for diminutive rectosigmoid adenomas, agreement with pathology-based surveillance interval, and assessment of endoscopist-related and procedural factors potentially associated with the quality of optical diagnosis. Results. A total of 1,650 polyps were found in 607 patients, with 1,311 polyps, 79%, being diminutive, of which 672, 53%, were adenomatous. The NPV of optical diagnosis for rectosigmoid adenomas was 95%. The optical diagnosis-based surveillance interval agreed with the pathology-based recommendation in 93% of patients. Prior experience with image-enhanced endoscopy had no effect on optical diagnosis. Low and high adenoma detectors were not different in achieving the quality benchmarks. Cap-assisted colonoscopy was not associated with quality of optical diagnosis. Quality metrics of optical diagnosis remained similar during the first and second half of the study period. Conclusion. High-quality optical diagnosis of diminutive polyps can be achieved and sustained by endoscopists previously inexperienced in this practice with minimal training. None of the examined factors appear to affect the quality of optical diagnosis. Particularly, endoscopist adenoma detection was not associated with optical diagnosis.